Thanks for joining the American Ambulance Association webinar. The webinar is being recorded. The on-demand archive will be posted to the AAA website within 48 hours of the live session and will be included in the next AAA Member Digest e-newsletter. A link to the slides for today's session will be posted in the chat shortly and was included in today's reminder email. To ask questions, please use the Q&A function, double dialogue bubble button. The chat will be disabled for participants. Brian, the floor is yours.
Thank you, Ben, and good afternoon to all of you, and good morning to those of you joining us on the West Coast. So, a little bit of an hot button topic these days has been certainly VA coverage. So, we thought it might be a good time to just sort of review the rules, at least as they're written, and then just sort of dive into sort of more of the practical aspects of this. As with all AAA webinars, just a reminder that while I am an attorney, this is not officially legal advice. And in the event you would need legal, financial, or other accounting advice, we certainly encourage you to seek the advice of your local professionals. Um, so when we talk about the VA's coverage, there's really no other way to put it. It is just a convoluted mess. Um, there are multiple different programs. We will certainly talk about all of them. And then we will talk about some of the practical difficulties, both on our side and on the VA side, in trying to actually take claims that you submit and the limited information that's on those, and then for the VA to try and properly process those. So the way I'd like to start is to pose a hypothetical to all of you. And I'm assuming that most of us on this call are either in the billing office of our respective organizations or have some basic understanding of billing processes. So what I want to ask you is this hypothetical situation. Today, your organization is called to report immediately to a patient that's reported to be having chest pain. Your crew documents that they found a 75-year-old male complaining of radiating chest pain. The crew treats the patient pursuant to your standing treatment protocol, so cardiac monitor, possibly an IV, etc., right? And they transport the patient to the ED at your local hospital, meaning not a VA hospital. While you're at the patient's home, the crew is informed by the patient's family that the veteran is enrolled in the VA health system. So the question that I will pose, and it's a rhetorical one, I guess, is under what program within the VA's health system do you believe that this claim should be covered? And I'll give you a number of possible options. So we have the Millennium Bill, which is 38 United States Code, Section 1725. We have the Program for Emergency Treatment, which is Section 1728. We have beneficiary travel, which is Section 1711. And we have the Veteran Community Care Program, which is Section 1702. So if you were to try and answer that question, what you would realize is that you actually need a bit more information. For instance, is it related to the patient's service-connected condition or service-related condition? Depending on the answer to that question, the claim would go, potentially under the Millennium Bill if it's unrelated, or under certain other programs, and this is where things can get a bit complicated. So I just wanted to mention that example just to sort of give you a sense of what VA claims administrators are actually dealing with. So let's start with the Millennium Bill. So the Millennium Bill was intended, was implemented by Congress as part of the Millennium Bill, so in 2000, and the idea was to provide for veterans coverage of last resort, and it was limited to emergency coverage. So the coverage itself is for emergency treatment that's furnished in a non-VA facility in connection with a non-service connected condition. So in theory, this should be the bulk of emergencies, meaning to the extent the VA is the appropriate payer, in an emergency situation, you would think, all other things being equal, the vast majority of them would fall under the Millennium Bill, because the majority of emergent medical conditions will be unrelated to a patient's service condition. So, for instance, that veteran may have lost a limb overseas, right? Chest pain is going to be unrelated to that. A car accident would be unrelated to that. Most traumatic injuries would be unrelated to that, etc. Right? In addition, there are certain coverage requirements that are specific to the veteran that must be met. So the patient must have been, or the veteran rather, must have been enrolled in the VA health system and seen a VA physician within the previous 18 months. And they also must not have any other healthcare coverage that would fully extinguish the patient's financial liability, with one big caveat. For these purposes, we're not looking at their cost share amounts. So if they have commercial insurance, but it doesn't pay the full bill, or doesn't allow the full bill, excuse me, then that additional amount, the balance bill, would be eligible. And when the VA pays as a secondary, they pay a surprisingly large amount, right? This doesn't apply to deductibles, co-payments, or, excuse me, deductibles or co-insurance. Sorry, let me say that again. This does not apply to deductibles, and it does not apply to co-payments, but it does in fact apply to co-insurance. That's as the result of a recent court decision called STAAB, S-T-A-A-B, which litigated over this issue of the financial liability. But that's sort of outside the scope of today's call. When the VA pays under the Millennium Bill, it pays 70% of the Medicare allowed amount. And if you accept that amount, you accept it as payment in full. Okay. Next, we turn to the emergency treatment program. So this is for coverage of an emergency treatment in connection with a service-connected condition. And it includes the transportation to or from. So if we were to stop right here, all emergencies where the veteran goes somewhere other than the VA emergency department, a VA facility, really there should only be two choices: the Millennium Bill or the emergency treatment, Section 1728. And the deciding factor should be whether or not the emergent medical condition is related to their service disability or not. If it is not, it comes under the Millennium Bill. If it is, it would come under the emergency treatment section. Now, the emergency treatment, when they pay under this program, and this is big, they make their payment methodology is expressly tied to beneficiary travel. And since beneficiary travel currently pays your full bill charges, that means that payment under 1728 is your full bill charges. If you accept it, you do accept it as payment in full, as with all government, or the vast majority of government programs. Then we have beneficiary travel. Beneficiary travel is the coverage for travel expenses that are incurred by the veteran in connection with care either at a VA facility or where it's been previously approved by the VA. And while it's not necessarily limited to non-emergencies, the vast majority of beneficiary travel is for scheduled appointments. And again, there are some coverage requirements. The veteran must either have a disability rating of 30 or higher, or if their disability rating is less than 30%, they must be going for treatment related to their service disability. And in addition, the veteran has to have an income that's below the maximum amount, and that's a sliding scale based on their disability rating. The higher your disability rating, the higher your income threshold before which, or above which, you become ineligible. So beneficiary travel under the beneficiary travel program, ambulance is considered what's called a special mode of transportation. And the reimbursement for special modes of transportation is based on actual costs, which has been interpreted by the VA to mean full bill charges. And as always, this is payment in full. So a few things to understand when you look at beneficiary travel. The first is this is what, if you were on the VA's industry day or the industry days, excuse me, last year, this is the program that they refer to as VA initiated travel. That's because beneficiary travel comes out of the travel office within each of the VA facilities. So again, since this is broader than just ambulance, and since this is meant to deal with appointments or scheduled appointments, the idea is that the veteran would make an appointment with their VA physician. They'd have to come into the VA facility, let's say tomorrow, right? They would call the beneficiary travel office and say, I have an appointment at the VA tomorrow. I need help getting there and back. If they need payment for a taxi or an Uber, the travel office would reimburse them for those expenses. If they need help with a medical provider, like an ambulance company or a wheelchair van provider, the VA travel office would then typically call their contracted providers. So the overwhelming majority of beneficiary travel is non-ambulance. Something like 99% of all beneficiary travel is non-ambulance. They don't have statistics on what percentage is wheelchair van, but the overwhelming majority, let's say 80% or more, are not even what we would call medical transportation, right? They're taxis, they're payment for gas, hotel lodgings if need be, things like that, that the veteran actually incurred and now is seeking reimbursement for from the VA. So that's in part why the program operates a bit differently than some of the other ones, and certainly a bit differently than all other sort of fee-for-service programs we're familiar with. Even within the ambulance component, the subset of all Benny travel, the other thing to keep in mind is that the vast majority of those trips are done by a VA contracted provider. Again, because it's the VA that's scheduling it, right? So this can create some problems when you are not a VA contractor and where you're called, for example, this is probably the most common example, to take a patient from a hospital, a non-VA hospital, to the VA for further treatment, right? You may be the contracted vendor of that non-VA hospital, and therefore they're going to call you to do the trip, but the VA didn't approve the trip in advance. It's eligible for beneficiary travel because it's ultimately associated with care at a VA facility, but since it's not approved in advance, it will not be paid unless you get approval after the fact. Now, this is different than the 72-hour approval that exists under the community care program, which we'll talk about next, but it still does need to be approved. And you'll know that this is the case because you're taking them either to or from a VA facility, right? Chances are if you're taking them from a VA facility, it's because you're the VA contractor. So this is really going to a VA facility where it's your relationship with the initial hospital that ultimately leads the trip to you. So just keep in mind, these claims will not be approved unless you are either a VA contractor and have a standing purchase order with them, or you get approval through the local VA's travel office. Okay. This is different than the community care program, which was, well, it's existed in various forms for probably about 3 decades now, but it tends to be the program that gets tweaked more than most. One of the reasons why it gets tweaked more than most is this is essentially the umbrella coverage for all of the other various programs, meaning if it's not covered under a more specific program, this is the program that gives the VA the largest latitude to find a way to pay for something. The other reason why it tends to get changed more than many is Congress is frequently reacting to stories about problems within the VA. Patients are waiting long times to get appointments. The VA doesn't have the capabilities to treat particular types of patients, and therefore they're forced to go to outside providers. So Congress does tend to tweak things in this program quite a bit. The most recent changes came about in 2021. But the basic gist is this is the coverage for care, including transportation to and from that care, when the veteran goes to get medical care from a non-VA provider. There are a couple of requirements, but they basically boil down to it's not reasonable to ask the veteran to go to the local VA facility, either because that local VA facility doesn't offer the type of care they need. This is frequently the case with, for instance, mental health services. They reside in one of the 3 states or the 4 U.S. territories that does not have a full service VA facility. So, for instance, if you reside in, I don't know, the U.S. Virgin Islands, there is not a VA facility on the islands. Therefore, you have no choice but to either fly to the mainland or seek care at a non-VA provider. Under that circumstance, they would approve care under the community care program. Veterans that were previously approved under the predecessor to this program, the Veterans Choice Program, are also eligible regardless of any other eligibility criteria. So if you were eligible under the Veterans Choice Program, you're grandfathered into this program, even if you live next door to a local VA, right? But probably the 2 most likely reasons why the VA would pay under the community care program are that the wait time to get an appointment for whatever the patient's needs are exceeds their current wait time standard, which I believe is 30 days. Excuse me, I believe it's 20 days for generalist care and 30 days for a specialist. Or the local VA doesn't meet the VA's quality standards, which is an interesting way of handling the problem, right? The current VA facility is not up to snuff in terms of their quality. So rather than fix the quality issue, we'll just allow veterans to go elsewhere. If that strikes you as a bit odd, welcome to VA, the world of VA healthcare. There are a lot of things that will not make sense as we get a little bit deeper into this. Like right here, when the VA pays under the community care program, by law, they are supposed to pay 100% of the Medicare allowed amount as payment in full. However, what is happening frequently is they will pay your full bill charges. And we'll get into why that might be in a little bit. So this wraps up the coverage itself. Sorry, I should mention that when a veteran is transported in an emergency situation, and their definition of emergency is not necessarily limited to the situation where you are billing with an emergent HCPCS code, A0427 or A0429. It's really more about, basically, it's not scheduled, is sort of the definition they use for emergency. You are required to get approval of the trip within 72 hours after the date on which the trip occurs. And if you don't get that approval, then the claim will be denied. Now, I will mention that the VA has recently indicated that they are rethinking the 72-hour requirement. In part, that's because of all of the issues that have sort of spun up, come to the surface as part of a larger debate about their reimbursement methodology and the changes they were proposing to make to the beneficiary travel program. But it's also based on a bunch of other problems that have been identified as sort of during their industry days and some town hall meetings they've held. And that's prompted Congress to sort of start asking some questions, and the VA, frankly, doesn't have very good answers to them. And as a result, there is legislation that is being proposed that would extend the 72 hours to 30 days. That the purpose of that is because the veteran always has the right to notify them within 30 days. So under the current rules, if you don't get approval within 72 hours, the VA would have no choice but to deny the claim. You would then have the right to bill the patient. The patient would then have the right to go to the VA to get it approved. They have 30 days to get it approved. If they get it approved, it becomes beneficiary travel, at which point you would get paid, and in fact, you would get paid at your full bill charge. So again, there's not a lot of structure to this. I think the key point for all of us, though, is the level of detail that's involved in each of these programs is such that in order to properly adjudicate a claim, the VA would need a lot more information than the typical healthcare program. So for instance, in Medicare's world, there are three basic requirements for coverage. There are a lot of technical requirements, but the three basic ones are that the patient have Medicare Part B coverage, that they be transported to a covered destination, and that the transport be medically necessary. Your Medicare contractor can look at the common working file to see if the patient is in fact enrolled in the Medicare program. In fact, that happens before the claim is even adjudicated by the MAC. So when you send in a claim to your Medicare contractor, you send it to, say, Novitas. Before Novitas even looks at that claim, they send it off to the common working file to scrub it against eligibility. If the patient is eligible, it comes back to Novitas. Then they run it through their claims processing edits. They would know that it's a covered destination based on the modifier. It's an H. Anywhere to a hospital is covered, right? Then they would use the ICD-10 codes to determine medical and or the billing narrative to determine medical necessity. But there's a lot more information that the VA needs. For instance, they would need to know what the patient's service-connected condition is. They would also need to know whether or not this treatment is related to that. That sort of information wouldn't necessarily make its way onto your claim because you're documenting why they need an ambulance to get from point A to point B, not whether or not it's related to an underlying condition, right? So if you want to summarize this, the key point is that the level of detail that exists on the typical ambulance claim is insufficient for the VA to make the proper determination in order to take that claim and put it in the proper program. So as a result, the VA is forced to take a much more pragmatic approach. And they are trading accuracy in order to do so. So the way the VA really processes claims is, and again, if you recall, earlier I had mentioned that beneficiary travel is administered out of their travel offices within the individual VAs. You also have what's called the Veterans Integrated Service Network, or VISNs, which is where you send your claims if you send them electronically. If you send them on paper to the local VA, they scan it in and send it electronically to the VISN. So what ends up happening is a claim that goes to the patient travel office for care that they've previously approved, or that goes to or from a VA, is put under the beneficiary travel program, and they will then judge it based on its merits there. If they're going to or from a VA, by definition, it is going to be service related, right? Other claims, including that first example we gave earlier, which is an emergency trip for chest pain, which is likely unrelated to a service condition, going to a local non-VA hospital, you would submit to the VISN. Whether they admit it or not, the VISN will assume that it is related to the patient's service-related condition, because from their perspective, why else would you be sending it to them? Meaning they're ignoring the Millennium Bill. So as a result, if you've recently moved over to ECAMS, which was their new electronic claims processing system that went online in 2019 and 2020, what you would have likely seen is a large shift in the number of your claims that end up being processed under the Millennium Bill, because the ECAM system appears to assume that everything is service related, whether they are right or wrong. If you submit on paper to the local VA office, they may scrub it for service related or not before sending it on to the VISN. So one thing that is clear from talking to various providers is those that submit on paper see many more claims processed and paid under the Millennium Bill than their counterparts that submit their claims electronically directly to the visit. And that has some actually important implications on payment, because under the Millennium Bill, you get 70% of the Medicare allowed amount, whereas if it's processed under either emergency treatment or the community care program, you end up typically getting your full bill charge. So two identical claims that simply take different pathways through the VA's payment system will end up being paid different amounts based on a judgment call. And that judgment call is being made by the travel office because they have the opportunity to look at the claim, whereas the electronic VISN does not, right? The other problem from the VISN's approach is it's very difficult for them to know whether or not it's related to an emergent condition or not. Yes, you will have billed an emergency, but they don't treat the HCPCS codes as indicative of emergent versus non-emergent. So when you bill, for instance, an emergency claim, A0427, an ALS emergent base rate, from a non-VA hospital to the hospital, they will frequently treat it as a non-emergency and apply the community care rules. Although the community care rules can also cover an emergency. Again, this is complicated. So because the VISN can't really know if it meets the requirements of emergency treatment, 1728, they tend to process everything under community care because that's the broadest coverage that they have access to. One other interesting tidbit is the community care is supposed to be 100% of the Medicare allowed amount. Emergency treatment, 1728, references beneficiary travel, which is paid at full bill charges. So the VA will tend to put everything under community care because it's simpler for them, but then they will tend to pay it at full bill charges because they can't rule out the possibility that this particular claim is emergency treatment, not community care. So they make a number of guesses, and in many cases, they're being overly conciliatory to both the veteran, covering it under the broadest possible program, and the provider, paying it at the highest possible amount in order to avoid problems down the road, right? So a good chunk of the problems we have with the VA really stem from the fact, when you get right down to it, that they're trying to be fairly generous to both the veteran and the provider community. One, we're not used to plans that bend over backwards to pay claims. So as a result, it sort of takes us out of our typical mindset, which is all these plans care about is denying claims, right? The other thing is they're not very good at it. And they inadvertently create some problems for us with things like the 72-hour rule as a result. So keep this in mind when you look through it. So now the question is going to be, if you're the VA or if you're the higher ups at the VA and you've realized that the beneficiary travel program, or more broadly, the total amounts that you've been paying for transportation to ambulance under all your various programs has increased dramatically in the last 15 years. What do you do? Well, they proposed in February of 2020, in November of 2022, they proposed. In February of 2023, they finalized a rule that would revise their payment methodology for beneficiary travel. They would take beneficiary travel's reimbursement down to the lower of your billed charge or the applicable Medicare allowable. And they initially were going to have this go into effect in February of this year. So at the time, the VA estimated that the total financial impact was just under $40 million. That is correct if you only look at, sorry, I should back up. Because beneficiary travel is primarily done by contracted providers, this rule would only apply to covered beneficiary travel that is done by non-contracted providers. So as a result, the financial impact is relatively minor. It's about $40 million. That's because, one, the vast majority of beneficiary travel is non-ambulance. Two, the vast majority of the ambulance travel under the beneficiary travel program is done by contracted providers. So there are very few trips that would actually be impacted under the beneficiary travel program by this. That being said, we still think that they underestimated it because based on their own data, the Medicare allowed, they estimated the Medicare allowed amount to be about 86% of the average billed charge. But when you look at the CMS data for the same date range, the average allowed amount ranges from between 24 to 43% for ground ambulance. In other words, unless the people that are billing the VA happen to be providers that charge relatively low amounts, and therefore their billed charges are closer to the applicable allowed amount under Medicare, it may just be that they have bad data. And this is particularly true for air because those rates tend to be significantly higher. However, and this is the big caveat, the reimbursement methodology for beneficiary travel doesn't only affect beneficiary travel. Emergency treatment, that's 1728, is expressly tied to reimbursement at the level and amount under beneficiary travel. So by lowering beneficiary travel, you would also be lowering the amounts that are paid for emergency treatment. And because the community care program, which is already supposed to be at 100% of Medicare, but which they can't implement correctly, they would frequently pay full bill charges as well. And then we have this other issue of millennium bill claims becoming community care, which takes them out of one, the 70% of Medicare allowed amount reimbursement, and then two, should have put it to 100%, which wouldn't have been a big deal, except they incorrectly then pay it at the full bill charge. So when the AAA did its own estimate based on the VA's own data, these are the amounts they were actually paying for everything on their fee-for-service side. So this is emergency treatment, community care, and millennium bill. We don't know what percentage of millennium bill, but we do know that the percentage of millennium bill claims has dropped dramatically since they went to their electronic claims filing system. But basically, in fiscal year 2022, the VA paid 1.6 billion with a B dollars. If you took all of their various programs to the Medicare allowed amount, it would save 1.4 billion. You would see particularly big hits in the air ambulance regime. So for instance, 90 some odd percent of 90 some odd percent of air ambulance reimbursement would disappear once it was linked to the Medicare allowed amount instead of full bill charges. But you see fairly large decreases across the board, especially in the emergent base rates, A0427 and A0429. So the conspiracy version of explaining the proposed final rule was that it was a way for the VA to address its larger issue, which is it's paying millennium bill claims incorrectly, it's paying community care claims incorrectly. By taking the highest amount they could possibly pay down to the Medicare allowed amount, they would eliminate all of those other problems. So that conspiracy theory view is that this was a way of quietly fixing a much bigger problem. And here you're seeing the numbers. It's a $1.4 billion problem. This helps explain why the industry's reaction to this rule was so vehement. It was only $40 million in terms of beneficiary travel. The VA's estimate on that is likely correct, right? But the industry was, and in particular the air ambulance side of our industry, was complaining because of that much larger $1.4 billion. And just to put it in perspective, they were paying $1.6 billion, which is about 1/3 of what Medicare pays on less than 5% of Medicare's volume of claims. So from their perspective, they were certainly overpaying for ambulance. So this resulted in all of those various industry days and all of the various complaints, up to and including a lawsuit filed in federal court That lawsuit um, was challenging their authority to implement the rule because they were implementing it for all beneficiary travel. But the congressional authority given to them to do so was limited only to claim for transports to or from a VA. So keep in mind, beneficiary travel is not just to or from a VA, it's to or from a VA or any other trip that's approved by the VA. So essentially, what they were saying is in expanding it to include all beneficiary travel, you exceeded the congressional mandate. Therefore, you had to follow the Administrative Procedures Act, go through notice and comment rulemaking before you could make any change to the reimbursement. And since they didn't do that, they were arguing that the question was inappropriate. So there was a question, who was the lawsuit filed by? It was a number of different EMS agencies. The lead plaintiff was MedStar Mobile Integrated Health in Fort Worth, Texas, but it included a number of public entities, including, I believe, the Three Rivers Ambulance Authority, and then a handful of fairly small plaintiffs. But to be perfectly honest, that group was simply the first to file a lawsuit. There were, to my knowledge, at least half a dozen other lawsuits that were getting ready to be filed, essentially making the same argument. So I think the plaintiff is less important than the argument in this instance. But in any event, partly in response to that lawsuit, partly in response to the fact that Congress was, or certain members of Congress were discussing proposed legislation that would have changed things or forced a delay, et cetera. And then I don't think the VA anticipated some of the outrage or concern on our side. And if you listen to those industry days, they frankly had no good answer to the issue of contracting. They were saying that they'd be able to contract with all providers for emergency services, before the implementation of the rule. And at that point, it was 6 months out. They were shocked to realize that there were 13,000 plus 911 providers, all of whom would potentially need contracts, right? One thing I will mention is if you were part of that discussion on the industry days, or if you listened to it, there was a big gap. So what the VA was saying is, if you'd like a rate higher than Medicare, you can only do so under a contract. And then the discussion became about whether or not it would be possible to contract, right? At no time did the VA say they would be willing to contract for an amount that was higher than that. And there's really no reason to think that they would, because again, these are emergency trips, 911. You don't have a choice on whether you do the trip or not, right? And if you do the trip, what's their incentive to pay you more than the Medicare allowed amount? They can just say no and get to the Medicare allowed amount. So unless you happen to have a particularly high volume of non-emergent VA claims, that would essentially force them to deal with you. And as part of that negotiation, you could then negotiate on the emergent side as well. It's unlikely that contracting is really the way to handle the emergent 911 trips, at least in terms of reimbursement. But from their perspective, the VA was thinking that they need providers that are willing to take patients to anywhere in the state. So as a result, they showed a heat map for the state of Michigan. They had 4 providers, and therefore they covered the whole state. They thought they were fine. They were surprised to learn that there are probably 300 or 400 EMS agencies in Michigan, all of whom would want to talk to them about contracting. So the notion that they could contract, even if they were willing to, with every EMS agency that was willing and able, is just simply not practical in the real world. In any event, what this ultimately led to was the VA withdrawing the implementation date of its final rule. So rather than have it go into effect in February of 2024, they instead indicated that it would go into effect in February of 2025. That's clearly just a placeholder. They're really just trying to buy time while they sort of sort through these issues. And I think they're sort of hoping that Congress will act one way or the other to take them off the hook for this policy because they haven't really taken any steps to try and do contracting or at least step up their contracting. So I'm going to pause and go back to the 72-hour notification for emergent care. Um, and the question is, am I recommending that providers complete the 72-hour notification to report the emergent care? I would. If you are not a VA contractor, you cannot control which program they adjudicate your claim under. If they elect to adjudicate it under the community care program and you don't have approval within that 72 hours, they will deny the claim. Yes, you can then go to the veteran and bill them and ask them to intervene and go seek reimbursement under Benny Travel from the VA, but there's no guarantees. It would still need to be approved by the VA at that point anyway. So my suggestion certainly would be, if you're in a position to do so, I would give that 72-hour notice. It's just a better safe than sorry. And I understand, there was an additional comment that said this individual indicated that they spoke to the VA and was told by the VA that they didn't want them to get the authorizations. I don't doubt that that's true, but in terms of protecting your organization, they may process it under a program that requires authorization or approval. I would be getting that approval. Now, there's nothing that says they can't give you the approval after 72 hours. When they do, they then adjudicate it under the beneficiary travel program, which is good for you because it means you get your full bill charges. But again, this is one of the reasons why certain members of the AAA are pushing legislation that would extend that 72-hour rule to 30 days for the notice, just to align it with the veterans notification provisions. The argument is it's inefficient for you to bill the VA, get a denial, then have to go to the veteran, and then have them get approval, all within 30 days. As you know, the VA frequently sits on claims, right? It would make far more sense if the VA is going to ultimately approve it anyway, for it to come from you, the ambulance provider, and now extending and giving you the same 30 days the veteran has. So this rule is, of course, a mess. And I guess we are through the prepared presentation. So I will open it up to questions. Just as a reminder, if you have a question, please use the QA dialog box rather than the chat one. It's just easier to see it all at once. But all right, what's everyone got? What do you want to talk about? All right, so we have a question, which is where or who do you call for pre-approval? Is it the responsibility of the hospital call for approval when the patient is a hospital discharge? It's a good question. You can do the approval in one of two ways. Probably the easiest is to contact the VA facility that's local, ask for the travel office and ask for the approval through that office. They may very well give you a different phone number, but that's where certainly I would start. The second question is it the responsibility of the hospital to call for the approval? Short answer, no. You can certainly, in your agreement with the hospital, shift that burden onto them. But from your perspective, if they don't call, you're the one that would see the denial. So if you are going to try and push this onto the hospital, and that's one that I do agree with, you would need to build in an enforcement mechanism, which is to the effect of if you don't get the approval, hospital, and as a result the VA denies the claim, I'm going to look to you, the hospital, to make good, right? So you do need that bit of that carrot and stick. Probably should have mentioned this earlier. Yes, the presentation will be available for download on the AAA's website. Usually that's one of the first few words out of my mouth, so I apologize if that was one of those things that you were thinking of and for keeping you in suspense. Crystal wants to know that if Medicare pays and then the VA pays in full later, who gets refunded for the overpayment? So this is a really good question. So when the VA is a little bit unique. I realize that you can't be a little bit unique. You either are or you are not unique, but in this case, they are somewhat unusual, let's say, in the sense that they do not really fall within the hierarchy of coordination of benefits. So, for instance, when we talk about Medicare and Medicaid, we say Medicare is primary to Medicaid, right? The VA is either the payer or they are not the payer, the one exception being under the Millennium Bill. So when a veteran has both VA coverage and Medicare for a service-related condition, they have a choice as to whether or not they would like Medicare or the VA to be their primary. If they elect, Medicare doesn't know. So Medicare will always adjudicate the claim as if they are the primary. So they will pay you whether or not they should have paid you. If the VA pays you, that is proof that the VA believes that they are in fact the payer. So in a situation where both Medicare and the VA pay you, the VA is the payer, I would refund Medicare, right? A twist on this is you bill Medicare and then you're informed by the patient that are in fact a veteran, they'd like you to bill the VA. Why would they do that? Because the VA doesn't have cost shares, whereas Medicare does. But as a general rule, if the VA will only pay you if they are the payer. So if the VA pays you, you can accept that, it's payment in full, and then you can refund any other payer, Medicare, Medicaid, etc., that may have also paid you. My advice is not to try and sort out what the patient's preference was. I would bill both payers. Again, if Medicare is likely going to pay you because they may not even know about the VA, but even if they know, they don't know the veteran's election or whether it's service related or not. So they're just paying you under Medicare's rules. The VA is presumably adjudicating under its much more restrictive rules. So if it pays you, it's the payer. Laura asked, what is the timely filing period? We can't seem to get a straight answer from the VA. I don't doubt that you can't get a straight answer. I don't think they honestly understand the rules. It varies based on the program. So the Millennium Bill, I believe, is 6 months. But the shortest time period under any program, I believe, is 90 days. So that's yet another reason why I wouldn't wait to bill the VA. For instance, their time limit is significantly shorter under any program than Medicare's requirement, which is 1 year. So I would, if you're aware that the VA is a potential payer, always bill the VA as soon as reasonably possible and make that notification if you do, right? Keep in mind, if you know that you need to get this, if you make the notification within the 72 hours, you've pretty much already decided that the VA is going to be the payer. There's really no reason why you would ever need to bump up against its time limits at that point. And if you wait 6 months, and it turns out that it's community care, you didn't get the authorization within the 72 hours, it's probably not going to be approved anyway. So the VA is one of those payers that you do need to move relatively quickly to get them out the door. The sooner the better is probably the best answer I can give. An anonymous attendee indicated that they were told that the VA, that it's the veteran's responsibility to obtain prior authorization from the VA. Technically it is, but if they don't, you don't get paid. So, look, this is similar to a lot of questions that get asked about various different programs. Shouldn't it be the hospital's responsibility? Shouldn't it be the patient's responsibility? It can be, right? Morally, yes, it's probably the patient's responsibility. But if you want to get paid, I wouldn't stand on ceremony here, right? So if you prefer to bill the VA, the veteran, just bill the veteran, right? Don't get in a fight about responsibility, right? You're not obligated to take the VA's payment. You can always bill the veteran, but if you're looking to be paid by the VA, you should take it upon yourself to ask for the authorization. Another question, when our non-emergency claims go through community care, they are automatically denied. Where should we be sending the non-emergency claims to? Well, I assume what we're saying is that we're submitting them through the VISN. It would depend on why they're denied, but I suspect they're being denied because you don't have the prior authorization, be approval within 72 hours. So if I'm not understanding the question correctly, please feel free to just provide a little bit of additional information. But if the reason they're being denied is because you're not getting the authorization, then that's the issue. It's not a question of where we're sending the claim to. Basically, unless it's Benny travel, meaning to or from a VA facility, if you're submitting electronically, it has to go to the visit. If you're submitting on paper, it goes to the travel office in all instances. So I wouldn't really be focused on the where. I would be focused on why they're being denied. I hope that helps. But certainly if I'm missing a piece of information, please feel free to, add a little bit more to it. Sonia wants to ask, we received denials from the VA requesting the emergency hospital records. In some cases, we obtain the records and send it to the VA. They still deny and request the record, but from the patient. What's your recommendation for such denials? So it used to be the case that under the Millennium Bill, because they had to prove that it wasn't service related, they also had to prove that the patient actually received care in the non-VA hospital. So they would typically ask for the medical records. Now the law did change. They no longer need the hospital's records to process your claim, but they're still within their rights to ask for the records under the theory that they need them to determine whether the care is service related or not. So I would certainly try and get them the records. But if you give them the records and they still deny it, again, it would depend on the basis of the denial. But the reality is they've denied the claim. So at that point, you would have to bill the veteran and suggest that they contact the ombudsman at their local VA. That's the individual that would then basically handle the appeal coming from the patient. Another insurance pays and we are being told to bill the VA as a secondary. Does it really pay? Yes, only under the Millennium Bill, but yes, they will pay. So we're typically talking emergencies that go to a non-VA facility here, and it's unrelated to a service condition. Yes, they will pay. What they won't pay, though, are deductibles or co-payments. They will pay co-insurance, though. So Medicare is a classic example where they may very well cover the co-insurance. Another question, Shauna is asking, we have had the VA tell our billing department that the billing department needs to get the records from the hospital and submit the ambulance claim. The hospital is not responsible for this. We know this is not true. Is there anything I can have the team refer to combat this? I think what I would say is, just as we are understandably confused about the VA's coverage rules, many of the people at the VA, and almost exclusively anyone that works at a VA facility, doesn't understand their rules either. So more likely than not, that individual is telling you they need the hospital records, but no one's ever told them why. If they need them because they think it's required under the Millennium Bill, they are incorrect. The law was changed a few years back. If they need it because they believe it's necessary to determine whether or not it is service related, they are probably on solid legal footing. I don't know how I say if their hospital care is service related or not without having the hospital records. I know what the patient's service condition is, but how do I know if it's related or not, right? So rather than trying to fight this, I would get the records. The hospital is not responsible for sending the records. In fact, in many cases, the hospital may have a payer, Medicare Part A, but the veteran doesn't have Part B benefits. So the veteran hospital claim is being submitted to Medicare, which means it doesn't make its way to the VA without you. So rather than fight this one, I think you need to make your peace with the fact that unless you send them the hospital records, they're going to deny it. So you can either get the hospital records and send them in with your claim, or you can accept that they're going to deny it and then bill the patient and let the patient fight it out with the VA. Either of those are viable strategies. But if you have an understanding with that hospital, contractual or otherwise, they are allowed to provide you with those records under the HIPAA privacy rule. You're a covered entity, they are a covered entity. You need the records for your payment purposes. So the hospital can give you the records. They're not required to, but they can. So I would be asking for those hospital records anytime you're about to bill the VA. Edna says that we're seeing claims paid at 70% of the Medicare allowed amount, and we're told it's because of the PACT Act, which pays for psych transports at this rate. These patients are going to a VA facility for psych admission, but we were expecting beneficiary travel to cover it in full. Well, Edna, if you got it approved in advance, it would be beneficiary travel. The PACT Act is not relevant here, and more to the point, those are not emergency trips in the first place. So the Millennium Bill wouldn't apply either. So I suspect they're just processing them incorrectly. But the larger point would be you would need to give them prior approval for it to be covered under beneficiary travel. So if you're not doing that, then that's likely the ultimate cause. So this is probably a good example of where the VA's trying to be helpful is actually causing us problems. So from our perspective, it should be beneficiary travel, but maybe we didn't get it approved. So as a result, from their perspective, they should deny the claim. But rather than deny it, they're turning it under the Millennium Bill and paying you at 70% on the theory that something is better than nothing, right? But in our industry, we rarely just, accept that someone's trying to help us. So we naturally assume that there must be a mistake on their end. So if you're getting prior authorization, they should be paying it under the beneficiary travel program, and they are in fact making a mistake. If you're not getting prior authorization or post-trip authorization, then they should be denying it outright. So you can force the issue and tell them they should be denying it outright, or you can accept the 70% of Medicare and move on. I would probably take the 70% of Medicare and move on with my life, just because I suspect that billing these patients is not going to be a fruitful endeavor. So you said we've received timely filing denials when claims are not submitted within 30 days and the VA refuses to reconsider these. In some cases, the veteran informs us about having VA benefits after the timely period has passed. So I get the administrative difficulty. I understand that veterans sometimes don't always tell you they have VA coverage, but ultimately the burden is on us. So Sonia, I don't think they're actually denying it for timely filing. That may be the language they use. What they're really denying it for is they were processing it under the community care program and you didn't get an approval within 72 hours. So therefore it's not payable from their perspective. So one of the other problems with the VA is, of course, their denials don't always line up perfectly with the remark codes we're used to. If the patient does not notify the VA in 72 hours, are we able to bill the patient? Yes, you are, but just to clarify, it's not the patient's obligation to notify the VA. It is your obligation. Laura says that historically for us, community care doesn't pay for ambulance. It does. The program certainly covers travel to and from medical appointments. Now, it may get lumped under beneficiary travel if it's approved, and that might be what the VA is telling you. But if what we're saying is we bill them, they deny it, they're almost certainly denying it for the 72 hours, whether they say so or not. I'm probably not pronouncing this right, but Jovan is asking, where can we find the correct payer IDs to submit electronically? If you mean the payer ID for the VISN, you would have to physically enroll with them. And at that point, they would give you the correct plan ID numbers. Theodore asked, following up on the BLS non-emergency question, we're seeing more than 50% of our BLS non-emergency claims denied because it was not an emergency situation. So yes, I do have some insight on this one. I've had a number of discussions with clients. We're seeing the same thing. So what I think is happening is it's under community care because that's the broadest one, meaning it's service related. So the VA believes it's service related. They start under community care, but you don't have a 72-hour approval. Therefore, they're saying to the extent they're going to pay it, the only program that would allow them to pay it would be the Millennium Bill or emergency treatment. And since it wasn't an emergency, it's not eligible under either of those two programs. So again, regardless of the language they're using, what they're really saying is 72-hour notice. community care says one of the requirements is emergency transport. So maybe that's why they're denying based on the non-emergent code. Where do we send the non-emergency claims then? It's just to clarify, it's emergency treatment. The transportation does not exist in a world that is emergent or non-emergent in the VA's world. So no, it's unfortunately not the HCPCS codes. There are no easy explanations. It comes back to we didn't get a 72-hour notification. So this is just going to be a theme, unfortunately. We often bill for non-transporting paramedic services. We have had a claim denied because there was no transport. Christine, the VA is correct. They do not reimburse for EMS as a healthcare service. It's an administrative expense in their world. And since they didn't receive emergency treatment in a hospital, you wouldn't be eligible. Or you didn't provide a travel expense. So you would need to register with them as a healthcare provider, and they don't register ambulance companies. So I'm sorry, they do not pay the paramedic intercept benefit. Would we send the secondary VA bill to the same address we would if we billed them as a primary? Assuming we mean the VISN, the answer is yes. Sally says that the VA has started requiring emergency room records for patients going to the VA. They never did before. So again, this is one of those new things is as they've come to realize that they have not been adjudicating claims correctly previously, they realize that they need to make a service-related determination for emergency transports to non-VA facilities, and they believe they need the emergency room records. So you're going to need to start getting emergency room records. Sorry. Can we get a list of the addresses that claims should go to if they were for non-emergency transports only? It's going to be the visit. So there is, if you go onto the VA's website and search for the Veterans Integrated Service Networks, they will give you a list of the appropriate VISN in your area. Right. What is the difference between beneficiary travel and fee basis? From the VA's perspective, they're different funding streams. Beneficiary travel comes out of their travel office of the local VAs and comes out of that local VA's budget or VA facilities budget. Fee basis is everything that all care that's done by a non-VA provider, meaning outside a VA facility or a VA health clinic, and includes all ambulance trips that are not beneficiary travel. And those go through the visit. We've been denied due to a requirement for hospital records on A to VA transports. Our VA facilities will never release records to us. Is this the bill the patient and let them fight it out situation? It shouldn't be, Christine, but unfortunately it probably is. So VA to VA is the very definition of beneficiary travel. So they don't need the hospital records there. I know your point is they should have them. It's the VA, right? So you can certainly bill the veteran. My suggestion would be to have them go back to the initial VA, right? And that might prompt a discussion about why the VA should be giving you the records, right? But in this case, at least you're fighting on behalf of a patient, not yourself, right? But Edna likes my suggestion of having the veteran contact the ombudsman for help. Is this a person at the local VA facility? Yes. Every VA facility has an ombudsman, difficult word to say. So for those of you that are not familiar with 18th century parliamentary procedure, an ombudsman is a person who's there to liaise with the general public. Or put a different way, it's their, they're a fixer, right? So hopefully more along the lines of they're there to advocate on behalf of veterans with the VA. So this is squarely within their job description. This is a person that I think all of you, certainly if you have a VA facility you interact with frequently and you're not already a contracted provider, should go out of your way to make a relationship with. They can be a tremendous help in terms of avoiding all these problems as they come up. So flurry of questions there at the end. Nice job, everyone. I think this is the high point for a number of questions that have come, at least on a webinar I've done this year. I believe Scott Moore topped me on his OSHA presentation. I'll just leave you with a couple of quick thoughts before I take us out here. The first is don't underestimate the VA's ability to screw things up. So what that means is you may have figured out a process that works today. Tomorrow it may stop working for no other reason than someone different in the VA took over that job responsibility. There was a tremendous amount of turnover in the administrative office at certainly the beneficiary travel offices within the local VAs. So if you have a process that works, keep using it. When it stops working, it's not, I wouldn't necessarily say don't ask yourself why. I would just suggest that at the end of the day, the why is less important than what's the new process we're going to need to implement. So this is absolutely one of those situations where, much like being married, you can choose to be happy or you can choose to be right, but you can't be both, right? So choose to be happy. If they want the hospital records and you're in a position to give it to them, give it to them, even if you don't think it's necessary. If you're not in a position to give it to them, consider billing the veteran and letting them work it out. If for no other reason, it may prompt a conversation with that ombudsman where you can say, you don't really need the hospital records for this, right? And then hopefully maybe the travel office will get moved past that. So there is no right answer. Dealing with the VA is really more art than science. What should happen frequently doesn't. What's unusual is that it frequently or historically is accrued to our benefit. When they pay incorrectly, they tend to pay us more than they probably should, but they're now aware of it. That's prompted them to look at not just the payment amounts, but a lot of the coverage policies in general. My own personal take, and in discussing this issue with congressional legislative aides, is I think everyone agrees that at least with respect to the coverage of ambulance, the multiplicity of programs doesn't help. It just makes things more complicated than it needs to be. Frankly, I think they need to blow the whole thing up and start over and just essentially implement something similar to Medicare or something similar to TRICARE in terms of their coverages. But until that happens, we're just going to have to muddle through this the best we can. If you've got a process that works and it's different than what I told you on this call, you're right, I'm wrong, continue using your process. If you have a process that used to work and now it doesn't, we're going to have to try something different. And if you're taking anyone anywhere that has VA coverage that you know about, call them within 72 hours if it's possible. That will eliminate the vast majority of the denials, or hopefully eliminate the vast majority of the denials. So with that, I thank everyone for their time. You see my contact information there. That is my cell phone number. So if you have a question, certainly feel free to call. One of your benefits as a AAA member is you have access to experts or consultants like me and the many other consultants we have on various topics. I'm happy to help if I can. And with that, Ben, I'll turn it back over to you. We may have lost Ben there. All right. Seeing as Ben is no longer here, I will encourage everyone to disconnect. And I hope to see everyone on the next webinar. Have a great day, everyone.